Okay, so today we're going to continue with our discussion of interstitial lung disease, and we were talking about chronic interstitial patterns and the approach that we would use on chest radiography. Last time we covered much of the interstitial diseases that would give you an upper distribution of interstitial disease on chest radiography, and today we'll talk about diseases that are associated, or many of these diseases anyway, associated with a lower lung distribution of interstitial disease on chest radiography. Of course, as always, the clinical history is the most important thing when we are dealing with our differential diagnosis of interstitial lung diseases. If I tell you this patient has shortness of breath and we look on this close-up chest radiograph, we see increased interstitial markings here and a lower lung distribution, and we think about what things this could possibly be. And we do a CT scan, and here are the images from the CT scan. And you look at this and we realize that there is some parabronchial thickening here, some slightly dilated bronchi, as you can see, also some tree and bud nodular opacities. So this patient has airway disease and bronchiectasis. So bronchiectasis can give you what looks like an interstitial pattern here on a chest radiograph, even though we don't think of bronchiectasis as an interstitial lung disease. So we all know about the CT finding of bronchiectasis called the signet ring sign, where the bronchus should be the same diameter as the accompanying blood vessel. However, when we have the appearance where the bronchus is more dilated, then it looks like a ring. The classic is the signet ring, although in reality it really looks more like a pearl ring, because that's a CT finding of bronchiectasis. Is another nice example. Looks like interstitial disease on the chest radiograph, but if you look carefully, you can see these ring shadows, which is a finding on chest radiograph associated with bronchiectasis, and that is confirmed here on CT. Now, there are various causes of bronchiectasis that can be from chronic aspiration. Usually, though, bronchiectasis results from recurrent infections. This patient had an underlying immunodeficiency that resulted in recurrent lung infections causing bronchiectasis. Another patient who's short of breath, who has increased interstitial markings, somewhat reticular nodular pattern. There is a clue. You can see that the metaport here is in place, so we're thinking maybe this person has underlying cancer. And when we look on the CT scan, we can see that there is interlobular septal thickening here, outlining the secondary pulmonary lobules, but we also notice that it's somewhat nodular. So nodular interlobular septal thickening is associated with lymphangitic carcinomatosis. So that can also give you an interstitial pattern on chest radiograph. We've covered lymphangitic carcinomatosis before, and this is where the lymphatics are permeated with tumor cells, and that will give you an interstitial pattern on the chest radiograph. So this can occur from hematogenous spread, or can occur retrograde as the tumor spreads from affected lymph nodes into the adjacent lymphatics. There is a high positive yield with transbronchial biopsy. So here are the abnormal tumor cells here within the lymphatics on this micrograph. And if we suspect lymphangitic carcinomatosis, you can recommend transbronchial biopsy, as that can give you a diagnosis. We've discussed the tumors that can do this. Lung cancer and breast cancer can be unilateral. They can give you an asymmetric pattern of lymphangitic carcinomatosis. Upper abdominal tumors like pancreas and stomach cancer can also give you lymphangitic carcinomatosis, and then colon and prostate, of course, can also do that. Chest x-ray is often normal. However, in some cases, we may see an interstitial pattern, as in this example. You may see curly B lines also, as in this example, as that also represents interlobular septal thickening. Other findings, pleural effusion adenopathy, can also be associated with this. Realize that the lymphatics run in the periphery of the secondary pulmonary lobule and also along the bronchovascular structure. So those are the green areas here in this diagram. And so these areas can be affected with tumor when you have lymphangitic carcinomatosis, and that's why we get this interlobular septal thickening. And this kind of nodular interlobular septal thickening can be typical of lymphangitic carcinomatosis. As you said, breast cancer can give you an asymmetric pattern. This is a patient with breast cancer. It looks like there's unilateral interstitial lung disease here. And then here on the CT scan, we can see the interlobular septal thickening and also all of these nodules here scattered throughout the lung. There is also disease on the other side, although it's not quite as bad. And this is breast cancer. So close up here on the CT showing you that interlobular septal thickening, somewhat nodular in appearance from breast cancer in this patient. Here's an example of lung cancer. Here's the tumor here, and you can see the pattern of interlobular septal thickening spreading out from the tumor. This is lung cancer, giving you also an asymmetric pattern of lymphangitic carcinomatosis. Now, we don't want to confuse pulmonary edema with lymphangitic carcinomatosis. Pulmonary edema is the most common cause of smooth interlobular septal thickening. So pulmonary edema can give you smooth interlobular septal thickening. This interstitial pulmonary edema does not give you nodular interlobular septal thickening. Here's our next case. So this patient is short of breath, and we notice that there is an interstitial pattern here, and the distribution is somewhat striking. It affects the periphery of the lungs and also the lung bases here bilaterally as we look at this. And we look at the high-resolution CT, and we see honeycombing. So honeycombing is manifested as these stacked cysts here in the periphery of the lung in this case. So we have a subpleural distribution of honeycombing, somewhat more extensive as we get towards the lung bases. Well, this is a UIP pattern, or a pattern of usual interstitial pneumonitis associated with idiopathic pulmonary fibrosis in this patient. So this gets us to the topic of the idiopathic interstitial pneumonias. So this is a group of non-neoplastic, non-infectious lung diseases that results from damage to the lung parenchyma by varying patterns of inflammation and fibrosis. So not a very satisfying definition, but this is what we have. So these are clinical, radiologic, pathologic entities, meaning that diagnosis requires usually a combination of clinical findings, radiological findings, and often lung biopsy to arrive at a diagnosis. Hence, it requires a multidisciplinary approach. So the original classification of the idiopathic interstitial pneumonias goes back to Lebo, and he thought of these entities, these chronic interstitial pneumonias. He at first divided them into 5 types based on histologic appearance, and he did not think of these as separate diseases, but as fundamental responses of the lung to injury. So the lung was limited in the way it could respond to injury, and these patterns, regardless of the etiology, then reflect these limited responses of the lung to injury. So in his original description, he described UIP for usual interstitial pneumonitis, DIP, desquamative interstitial pneumonitis, BIP, which went on to be called bronchiolitis obliterans with diffuse interstitial pneumonitis, or BOOP, LIP, lymphocytic interstitial pneumonitis, and GIP, which at the time was idiopathic, giant cell interstitial pneumonitis, but we now know that this is a hard metal interstitial lung disease caused by exposure to hard metals like tungsten and cobalt. So this is no longer classified as an idiopathic interstitial pneumonia. Now this gets us into the alphabet soup of all of these entities that you need to be familiar with. But since Lebo first described those, there have been other entities also described. AIP, which stands for acute interstitial pneumonitis, NSIP, which stands for non-specific interstitial pneumonitis, RBILD for respiratory bronchiolitis associated interstitial lung disease, and PPFE, the most recent one, which is described, which stands for idiopathic pleuroparenchymal fibroelastosis. Now, it turns out that not all of these diseases are idiopathic. We know that DIP and RBILD are associated with smoking. Whether LIP exists as a standalone disease within the lung were somewhat controversial, as many patients with LIP have some other underlying autoimmune disease, and so most cases of LIP will be found associated with other underlying autoimmune diseases like Sjogren's syndrome and also HIV. Not all of these diseases are predominantly interstitial. We'll see that AIP, DIP, and what Lebo originally called BOOP, which we now call COP, or cryptogenic organizing pneumonia, that these are predominantly diseases of the air spaces as far as their manifestations, and not so much interstitial. Also, you must differentiate the idiopathic interstitial pneumonias from hypersensitivity pneumonitis and underlying collagen vascular disease, especially if there is lung fibrosis. And this is important for both the clinician and for the radiologist who is reviewing the information on these cases. So our understanding and classification are still evolving. So one of the early articles describing this, I've given you the reference here from 2002, and the most recent update to this as far as various societies coming together in a consensus description of these different diseases. That was in 2013, and I've also given you the reference to that article. So my description here will be based on that article from 2013. So in the most recent classification of the idiopathic interstitial pneumonias, these are divided into 4 categories. We have the chronic fibrosing idiopathic interstitial pneumonias, that is IPF and NSIP, smoking-related idiopathic interstitial pneumonias, DIP, RB-ILD, acute or subacute idiopathic interstitial pneumonias, COP and AIP, and the rare idiopathic interstitial pneumonias, LIP and PPFE. And so there is a distinction here between the histologic pattern and the clinical syndrome. The histologic pattern is what the pathologist will describe looking at the biopsy specimen. The clinical syndrome is the actual disease name we give to the disease, or the diagnosis we would give the patient. So the histologic pattern of UIP is associated with idiopathic pulmonary fibrosis. So NSIP, there the histologic pattern and the clinical disease have the same name. The histologic pattern of organizing pneumonia is associated with cryptogenic organizing pneumonia as the diagnosis for the patient. The histologic pattern of diffuse alveolar damage is associated with AIP as the clinical syndrome. DIP and DIP are the same. Respiratory bronchiolitis, that histologic pattern, if the patient is symptomatic, the diagnosis we give is respiratory bronchiolitis associated interstitial lung disease. And then for LIP and PPFE, both the histologic pattern and the clinical syndrome have the same nomenclature. So for reversible and self-limited interstitial diseases, here we have RB-ILD. This is related to smoking. If the patient stops smoking, then this can get better. Reversible with some risk of progression. We can see this in cellular forms of NSIP and some fibrotic forms of these other diseases. Then we have stable with residual disease, which we can see with some fibrotic forms of NSIP. Progressive irreversible disease with potential for stabilization, again with some fibrotic forms of NSIP. And the worst prognosis we see with progressive irreversible disease. We will see that with idiopathic pulmonary fibrosis and also with NSIP, especially towards the more fibrotic end of the spectrum of NSIP. Now, in terms of the high-resolution CT approach, what is it that we want to do here? We want to be able to describe the disease using standard terminology. We want to determine the distribution of disease, and there we're talking about the axial distribution, whether it's central or peripheral, and also in the cranial caudal dimension. Is it predominantly upper lung or lower lung? Probably the most important thing we want to do is rule out UIP. So we want to decide, as far as the imaging goes, is it typical of UIP or is it not typical of UIP? And we'll discuss the reasons for that in a minute. We want to decide if we're dealing with fibrosing versus non-fibrosing disease. So if there's honeycombing, traction bronchiectasis, architectural distortion, volume loss, these are all signs of fibrosis. And then we look for ancillary features, features like cysts, perilymphatic nodules, centrilobular nodules, tree and bud nodules, mosaic attenuation, pleural disease, dilated esophagus, whether the lung bases are spared, air trapping, because some of these ancillary features may point to an alternative diagnosis, which is not one of these idiopathic interstitial lung diseases. And so these ancillary findings might be cysts, perilymphatic nodules, centrilobular nodules, tree and bud opacities, and air trapping. Well, cysts, we've seen this can be associated with Langerhans cell histiocytosis or lymphangioliomyomatosis. Perilymphatic nodules, we can see that with sarcoid lymphangitic carcinomatosis, some cases of lymphoma. Centrilobular nodules, especially if they're tree and bud, we can see that with hypersensitivity pneumonitis. Tree and bud opacities usually points to infection and bronchiolitis, and air trapping, we can see that associated with hypersensitivity pneumonitis or a small airway disease like bronchiolitis obliterans. So none of these are idiopathic interstitial pneumonias, and so it is important to notice these ancillary findings, as this may lead you to an alternative diagnosis. So let's start with idiopathic pulmonary fibrosis, which is associated with the histologic pattern of UIP. Well, here I've given you some demographic information. Symptomatically, it has an insidious onset of progressive shortness of breath, cough, restricted lung disease. 5-year survival is only 20% due to progressive respiratory failure. The causes of death, of course, the most common is respiratory failure. Cardiovascular disease is the second most common, and it is thought that the chronic hypoxia results in an acceleration of underlying cardiovascular disease. And interestingly, lung cancer is the third most common cause of death. Extensive fibrosis in the lung does predispose the patient to lung cancer, and so you need a high index of suspicion for lung cancer whenever you are evaluating imaging studies on these patients. So with usual interstitial pneumonia, what we have here is a repetitive process of injury and repair that results in pulmonary fibrosis. So there will be multiple microscopic foci of injury that occur over time, over years, and then we get focal fibroblast proliferation, the fibroblastic focus, which is this area over here. This is what the pathologist will look for, this kind of clump of fibroblasts. This results in collagen deposition, recurrent microscopic injury, and then you get into this vicious cycle here where this continues on, and then we get progressive fibrosis and worsening of the clinical course, and then resulting in eventually it can result in death. So the pattern on histology is a pattern of alternating areas of normal lung tissue, acute injury, repair, and fibrosis, as there are different parts of the lung in different stages of disease. And this pattern is temporally heterogeneous, which is what the pathologist will describe, and this is typical of UIP. So there will be thickening of the alveolar interstitium with fibrous tissue and inflammatory cells, and the fibroblastic focus is what the pathologist will look for, but they will also look for this temporally heterogeneous pattern, which is why it's important to obtain lung biopsy from multiple areas in the lung for the pathologist to see if there are different stages of lung injury in the different areas. In end-stage disease, we get the honeycombing that can be extensive. So you get these cystic spaces here, predominantly in the periphery, more severe at the lung bases, in end-stage fibrosis associated with this disease. So on the chest radiograph, we have a bilateral interstitial disease that can progress to honeycombing, and the distribution of this is quite striking. It has an L-shaped distribution affecting the periphery and the lung bases. You may see these ant holes when we look on close-up on the chest radiograph, and this represents the honeycombing that we see on the CT. Lung volumes are often low because of the fibrosis and architectural distortion. So the L-shaped distribution here, low lung volumes, is the typical radiographic manifestations of this disease. When we look really close, we can see all these tiny holes within the lungs. This represents those areas of honeycombing that we can see on the CT. If you're not sure if there's interstitial lung disease on a chest radiograph, on the frontal view, the lateral view is often very helpful because the retrocardiac region should be relatively clear. When you look at the retrocardiac region on your lateral view and you see interstitial disease here and you see these reticular abnormalities and these tiny little holes, then we know that there is interstitial lung disease in this patient. Another example, typical L-shaped distribution of this reticular pattern in interstitial lung disease, which is associated with the UIP pattern or idiopathic pulmonary fibrosis. And then this is also what we see on CT. So here's a coronal reformatted view on CT. You can see this peripheral distribution of interstitial lung disease giving you this nice L-shaped pattern. And then we have these stacked cysts in the periphery, more severe at the lung bases. That is honeycombing. So in this diagram of the normal secondary pulmonary lobule, we see that in the periphery we have the interlobular septae. In the center, we have the centrolobular bronchiole, which we usually do not see on CT. And then we also have the centrolobular artery, which we can see on high-resolution CT. And so here's a micrograph, or actually a blown-up image here from a high-resolution CT with ultra-high resolution here. And you can see here the interlobular septa here in the periphery, and then in the center, we can see here the centrolobular vessels, here the centrolobular artery, then here's the little bit of the airway walls that you can also see in the center. The airway itself is usually not resolvable, the normal airway, the centrolobular bronchiole on a normal high-resolution CT scan. When there is fibrosis, we get distortion of all of this, and what happens is that the airways get stretched and distorted, and that's what causes the honeycombing that we will see on CT. So this represents traction bronchiectasis or traction bronchiolectasis. That's what gives us the honeycombing. So this distribution of peripheral subpleural honeycombing is the classic manifestation of a UIP pattern. There may be some areas of ground glass attenuation associated with this, but it is not a predominant finding. The predominant finding is a reticular pattern, predominantly in the periphery and subpleural regions, and especially this subpleural honeycombing with idiopathic pulmonary fibrosis, as we've outlined here in this image. Now, ground glass attenuation, this also merits a brief discussion. So what does ground glass mean? Well, ground glass is opacity that you can see through on the CT scan. You can see the underlying architecture. So ground glass itself is a very non-specific finding because many different things can cause ground glass. If you imagine this as a voxel of anatomy here on a CT, so normally we have air here within the alveolar spaces, and when we do a CT scan here, this is going to be very low in attenuation, and normally we will not see that as ground glass. If we have atelectasis though, and the air is removed, now we have more soft tissue here in the voxel, and this can appear as ground glass on CT. The same way, if we have interlobular septal thickening here, thickening of the interstitium in a patient, then that also increases the attenuation of the voxel on CT, and that can look like ground glass. If you have alveolar consolidation, something that fills up the air spaces, that can also appear as ground glass on CT. So ground glass on CT is a very non-specific finding that can be caused by interstitial disease, airspace disease, or sometimes just atelectasis. So here's an example here of some peripheral subpleural honeycombing. Then we have some areas of ground glass here also associated. And when you have ground glass here next to regions of traction bronchiectasis, the ground glass probably represents pulmonary fibrosis that is beyond the resolution of the CT scan itself. Traction bronchiectasis, even if you don't have honeycombing, is also a finding associated with lung fibrosis. So it's something that we want to look for when we're evaluating for interstitial lung disease. It tells us that we are dealing with fibrotic lung disease. So we look at the airway here and we notice that it is dilated. We also notice that it is somewhat irregular in appearance. Here are some more airways that are irregular in appearance. They have this beaded appearance, and there is some adjacent ground glass attenuation. So this tells us that there is a fibrotic process going on here, that these airways are distorted because of fibrosis. So traction bronchiectasis is a sign of lung fibrosis. Sometimes doing CTs prone can help you because you'd want to differentiate between dependent atelectasis and interstitial lung disease. So dependent atelectasis can give you ground glass opacity, but if we turn the patient prone, if it's dependent atelectasis, it should go away. But here we still have ground glass opacity, reticular abnormalities, and some cystic areas representing traction bronchiectasis in the periphery, so this person does have interstitial lung disease. Then here's an example with somebody with ground glass because of dependent atelectasis. We turn the patient prone and that goes away. This is an example with somebody with pulmonary fibrosis. We have ground glass opacity and a little bit of traction bronchiectasis here on the right side. When we turn that patient prone, the ground glass and the reticular abnormalities remain. They don't go away, so this is real interstitial lung disease. Now, the primary role of high-resolution CT when we're dealing with these idiopathic interstitial pneumonias is we want to decide, do we think it's UIP or do we think it is not UIP? Because if the clinical findings are typical of UIP and if the CT findings are typical of UIP, then that patient can be treated or given a diagnosis of idiopathic pulmonary fibrosis and can be treated for it without a lung biopsy. On the other hand, lung biopsy is usually recommended if there's an incongruence there, if the clinical symptoms do not match the UIP finding on CT or vice versa. So if the clinical symptoms seem like UIP or idiopathic pulmonary fibrosis and the CT scan looks like idiopathic pulmonary fibrosis, then the patient can be treated for idiopathic pulmonary fibrosis without lung biopsy. The other idiopathic interstitial lung diseases will usually require lung biopsy for definitive diagnosis. However, even if a UIP pattern is present on a lung biopsy, to make the diagnosis of idiopathic pulmonary fibrosis, you still have to exclude other disorders like collagen vascular diseases, drug toxicity, and even environmental exposures like asbestosis, because these can occasionally also give you a UIP pattern on histology. So the diagnosis of an idiopathic interstitial pneumonia usually requires the input of the pulmonologist, radiologist, and pathologist. So if I show you a CT scan like this and I ask you, is this a typical UIP pattern, a probable UIP pattern? Is it indeterminate for UIP or is it inconsistent with UIP? This is the decision that the radiologist has to make when looking at an abnormal high-resolution CT scan. So in this particular example, we have reticular abnormalities predominantly in the peripheral and subpleural regions. There is some traction bronchiectasis, but there is no honeycombing. So I will tell you now that this particular pattern, this is associated with a probable UIP pattern, and that does have significance in the way the patient will be managed. So this is something that we will be discussing next. So when we're looking at CT scan, we want to decide, do we think this is typical or probable UIP? What makes it typical UIP? For a typical UIP pattern, we look for reticular opacities, honeycombing, basal and peripheral distribution of disease, and no features that are inconsistent with UIP. So here we have a peripheral reticular pattern. We have peripheral honeycombing here. It's basal and peripheral in distribution. There are no other features here that are inconsistent with UIP, so this is a typical UIP pattern. If you have all of this without the honeycombing, that makes it a probable UIP pattern. So if we have reticular opacities, basal and peripheral distribution, and no features inconsistent with UIP, that's this example here. So we have some traction bronchiectasis, we have reticular abnormalities, it's in the peripheral and subpleural distribution. but there is no honeycombing, well, this is still a probable UIP pattern. Now, the clinical significance of this diagnosis of a typical UIP or probable UIP pattern is in these cases, if the clinical findings, the clinical manifestations are typical of idiopathic pulmonary fibrosis, a lung biopsy is not necessary, and the patient can be given a diagnosis of IPF and can be treated for idiopathic pulmonary fibrosis. So this chart here goes through the findings of a typical UIP pattern and a probable UIP pattern, and then we have findings that can be indeterminate for UIP or consistent with alternative diagnosis. If we have a typical UIP pattern on CT, 90% of those patients will have idiopathic pulmonary fibrosis or will have a UIP pattern on biopsy. If we decide the CT is a probable UIP pattern, it turns out 80% of those patients will have a UIP pattern on lung biopsy. On the other hand, even if we think it's indeterminate for UIP, or even if we think on CT that it's more consistent with an alternative diagnosis, in those cases, still up to 50% of those patients will have a UIP pattern on lung biopsy. But the difference is that these patients will then require lung biopsy to try to make the diagnosis of what their interstitial lung disease is, whereas these patients can be given a presumptive diagnosis of idiopathic pulmonary fibrosis and then treated for that disease. So what makes it indeterminate for a UIP pattern? If the distribution is variable or diffuse instead of being subpleural, if there is a fibrotic component here, so there is some traction bronchiectasis, but there may be some inconspicuous non-UIP features there. And if there are findings that are more consistent with alternative diagnosis, well, what might that be? Well, if there's an upper or mid-lung distribution, if there's mostly consolidation as opposed to fibrosis, if there's extensive ground glass attenuation, if there's extensive air trapping, if there are nodules or cysts. So these kind of are pointing you in a direction away from UIP, and so this would be consistent with an alternative diagnosis. However, when they go on to biopsy, still up to 50% of those patients might still have UIP on lung biopsy. Now, the reason why the diagnosis of idiopathic pulmonary fibrosis is important is that there is a therapy now, that these drugs are now available, and patients given a diagnosis of idiopathic pulmonary fibrosis, or patients that we decide on CT that have a UIP or probable UIP pattern, these patients can be treated without necessarily a lung biopsy first. So honeycombing, peripheral reticular distribution of disease, and honeycombing worse at the lung bases, so that is a typical UIP pattern. So what about some of these other things? So here we have some reticular abnormalities. We have traction bronchiectasis. Really, is there honeycombing or is there not? You might kind of question that. So this one we might call a probable UIP pattern. On the other hand, here we do have some traction bronchiectasis, but we have a lot of ground glass attenuation, more than we would expect in a patient with UIP. So that is more consistent with a non-IPF diagnosis. And in this example, although we have some reticular abnormalities and traction bronchiectasis, so the traction bronchiectasis telling us that there is fibrotic lung disease, we notice that there is a lot of air trapping. So air trapping is something that we usually do not associate with UIP. So this air trapping that is more consistent with a non-idiopathic pulmonary fibrosis diagnosis, especially hypersensitivity pneumonitis. So here's a patient who has interstitial lung disease. Again, we have this L-shaped distribution, but if you look carefully, there is another finding here in this case, and there's this opacity up here in the periphery of the right upper lobe, and that is a lung mass. So on CT, we can see the traction bronchiectasis, we can see some honeycombing here in the periphery. We also have some emphysema, but there is a lung mass. This is a patient with lung cancer. So remember that lung cancer can be a complication of idiopathic pulmonary fibrosis, and this is the third leading cause of death in patients with idiopathic pulmonary fibrosis. So when we're dealing with widespread fibrosis on a CT scan, have an index of suspicion for lung cancer and make sure that we look for it. Another complication of extensive fibrosis can be pneumothorax, as in this case. So these areas of honeycombing, some of those can break into the pleural space and can result in pneumothorax. So that is another complication of this disease. Here's another complication of idiopathic pulmonary fibrosis. So the patient has an idiopathic pulmonary fibrosis pattern here, probable UIP pattern here. 3 months later, the patient presents with worsening shortness of breath and diffuse ground glass opacity superimposed on their underlying interstitial lung disease. Well, what complication of idiopathic pulmonary fibrosis is this? Well, this is called acute exacerbation or accelerated idiopathic pulmonary fibrosis. And on histology, these patients will have diffuse alveolar damage superimposed on their pulmonary fibrosis. So essentially ARDS superimposed on their pulmonary fibrosis. And that manifests on CT as ground glass opacity superimposed on the pulmonary fibrosis, and these patients deteriorate clinically quite rapidly. So this is acute exacerbation of pulmonary fibrosis. Here's our next case. So here's a patient who's short of breath, and the high-resolution CT shows us these findings. So we notice that there is traction bronchiectasis, telling us that there is some fibrotic disease here. There's a lot of ground glass, though, more ground glass than we usually associate with a UIP pattern. We also notice that we don't have not so much in the way of reticular abnormalities in the periphery, and maybe there is some subpleural sparing here in the periphery of the lungs. So what pattern is this associated with? Well, here we look a little bit closer here, and we do see that there is traction bronchiectasis here at the lung basis, telling us that there is fibrotic lung disease. This is a NSIP reconstruction, so this can be useful if you're looking for air-filled structures like airways or emphysema. So this is a patient then with NSIP. So there are many conditions that can be associated with an NSIP pattern on biopsy. So if it's idiopathic, then it's one of the idiopathic interstitial pneumonias, but I've listed many conditions so they can give you an NSIP pattern on lung biopsy. So idiopathic NSIP, these patients have progressive shortness of breath. These patients can recover with steroids. The 5-year mortality, if these patients are treated, is not as bad as idiopathic pulmonary fibrosis, although the prognosis depends on the extensive fibrosis. The more fibrosis there is in the biopsy specimen, the worse the prognosis in these patients. So here we look at the survival curve of a UIP pattern, so you can see that the survival here is not very good. And fibrotic NSIP, although the survival is better, they still have a worse prognosis than cellular NSIP. So the more fibrosis there is with NSIP, the worse the prognosis. Patients with cellular NSIP, the survival in those patients is pretty good. So for the NSIP pattern, these patients on histology will have varying degrees of interstitial inflammation and fibrosis, but here it is temporally homogeneous, meaning that all areas of the lung are at the same stage of repair, kind of indicating that there has been one insult to the lung, and the lung is now trying to heal from that insult. So these patients, if it's cellular NSIP, they will have predominantly lymphocytes and plasma cells, whereas with fibrotic NSIP, they will have more dense collagen there in the interstitium. So as far as the chest radiograph, we might see ground glass opacities and consolidations and reticular changes, again predominantly to the periphery of the lung and at the lung bases. The CT scan for an NSIP pattern, mostly we look for ground glass opacity with traction bronchiectasis. So ground glass with traction bronchiectasis, and the most specific feature is this subpleural sparing. So subpleural sparing is another finding associated with NSIP. There is no honeycombing. NSIP is not associated with honeycombing. So we can have a cellular pattern, a mixed pattern, or a fibrotic pattern. The more you get towards the fibrotic end of the spectrum, the more this can resemble UIP in terms of the findings that we see on CT. Now, there can be NSIP that looks like UIP with predominantly reticular, less in the way of ground glass. You can have UIP that looks like NSIP, lots of ground glass, not much in the way of honeycombing. And so here, these cases will require lung biopsy for diagnosis. So cellular versus fibrotic NSIP, cellular will have more ground glass opacity, fibrotic NSIP will have less ground glass opacity and more reticular and fibrotic changes on the histology. You might even see honeycombing towards the more fibrotic end of the spectrum there. So now we move on. So here's a different idiopathic interstitial pneumonia. Here the predominant finding is peripheral consolidations. So if we have peripheral consolidations here associated with this idiopathic interstitial pneumonia, what disease are we dealing with? Now, the importance of this is that you might be the first one to suggest a diagnosis. These patients do respond to steroids. So at presentation, we can see these consolidations here. Often these patients are treated for pneumonias, and pneumonia doesn't get better, necessitating CT scan. And after steroids, note the marked improvement in the radiograph. So here we are dealing with cryptogenic organizing pneumonia, originally called BOOP, but that term became very confusing, so hence the preferred term now, cryptogenic organizing pneumonia. The histologic pattern that we see associated with this is the pattern of organizing pneumonia. And so organizing pneumonia is the predominant clinical and radiological abnormality. So what happens here is that it's a disease in the air spaces where they get organization of inflammation here in the air spaces, and then that secondarily extends into the bronchioles, giving you these fibrotic plugs that extend into the bronchioles, hence the original designation here of bronchiolitis obliterans with organizing pneumonia. But it is not primarily a disease of the airways, it is a disease of the air spaces here. And so with this organizing pneumonia pattern, there is this granulation tissue that occurs within the air spaces that secondarily then gets into the bronchioles, causing these plugs, these fibrotic plugs that occur within the bronchioles that the pathologist can also look for. And those fibrotic plugs are called Masson bodies. So these fibrotic plugs getting into the small airways, those are called Masson bodies by the pathologist. The architecture of the lung is preserved, and this is a temporally homogeneous pattern as far as the way the pathologist will look at the lung tissue. Now, this organizing pneumonia pattern itself on a lung biopsy is very nonspecific. So there are many diseases that we might see this with on a lung biopsy, including idiopathic organizing pneumonia or COP. So not so much that we need you to memorize these other causes, but realize that organizing pneumonia on its own on a biopsy can be associated with many diseases. So as a biopsy specimen itself, it can be a nonspecific finding, especially on a transbronchial biopsy. So since organizing pneumonia can be associated with many diseases, the presence of organizing pneumonia in a transbronchial biopsy is only of limited value without clinical and radiological correlation. So with this diagnosis of cryptogenic organizing pneumonia, that's why when we're dealing with these interstitial lung diseases, we want to put together the findings that we have on the clinical findings. We want to put that together with the radiological findings and the lung biopsy when we have it to try to arrive at a diagnosis here. So for cryptogenic organizing pneumonia, often these patients will present with cough and progressive shortness of breath, so it may mimic a pneumonia with low-grade fever. And often these patients are treated for pneumonia, but they don't get better, and that's what necessitates the CT scan. And on CT, we may see these peripheral consolidations, and you may suggest then that this might be a cause of, or that the case might be a case of cryptogenic organizing pneumonia, and then the patient will be treated with steroids, and the patient gets better, and that's how you know that you have the correct diagnosis, especially if you have not done a lung biopsy. So this distribution of peripheral consolidations here, and sometimes also parabronchiolar consolidations, so that pattern is associated with cryptogenic organizing pneumonia. This other sign has also been described in the literature associated with cryptogenic organizing pneumonia. And so this sign here, when you have these areas of opacity where they are denser towards the periphery and more ground glassy towards the central portion, this has been called the reverse halo sign, and this has also been associated with cryptogenic organizing pneumonia. Now, it turns out that this is not very specific, that there are many other things that can give you the reverse halo sign. We see a lot with aspergillosis infection, but realize as far as exams go that the reverse halo sign can be associated with cryptogenic organizing pneumonia, although it is not specific for cryptogenic organizing pneumonia. Another finding that we can see with this on CT is this perilobular pattern, where you have this kind of thickening of interlobular septae, somewhat disorganized appearance here associated with some ground glass opacity and maybe a little bit of architectural distortion. So this is a perilobular pattern of disease, which has also been associated with cryptogenic organizing pneumonia. So what happens is that the consolidations may increase or remain the same despite treatment with antibiotics. And if we notice on CT that there's a peripheral or peribronchiolar distribution of opacities, we may suggest cryptogenic organizing pneumonia patient is treated with steroids and gets better. So here's such an example, peripheral consolidations here in this patient. And after steroids, you can see that there has been improvement. There's been both symptomatic improvement in this patient along with radiological improvement of disease. So peripheral consolidations, that is the pattern associated with cryptogenic organizing pneumonia. Here's a patient who presented with shortness of breath and required intubation shortly thereafterwards. And so which of the idiopathic interstitial pneumonias can give you this appearance of opacities, especially worse here in the dependent portions of the lung? So this is a pattern that we associated with ARDS. So which of the idiopathic interstitial pneumonias can clinically present like ARDS and can also give you radiological manifestations of ARDS? Well, this is AIP, acute interstitial pneumonitis. So this was idiopathic, rapidly progressive interstitial pneumonia, first described by Hammond and Rich. So the Hammond-Rich syndrome really is AIP, or acute interstitial pneumonitis. Essentially, you can think of this as idiopathic ARDS. So it results from a single episode of lung injury. The cause is unknown. So essentially, this is idiopathic ARDS. So with AIP, there's massive injury at one time that results in diffuse fibroblast proliferation, and then the outcome depends on the extent of injury, as opposed to UIP, which is a repetitive process of injury and repair. So with UIP, you get primarily interstitial disease, where the fibrosis occurs in the lung interstitium. With AIP, when these patients develop this ARDS kind of pattern, you have a lot of material that spills out into the alveolar spaces, and then that is what becomes organized, that is what becomes fibrotic. So this is fibrosis by accretion. So with AIP, the patients will present with respiratory symptoms, and they deteriorate rapidly to respiratory failure, has a very high mortality. And again, as we've said, it's like ARDS. So just like ARDS, the pattern that we see on histology is the pattern of diffuse alveolar damage. So we've gone through the phases of ARDS before, the acute exudative phase, the subacute proliferative phase, chronic fibrotic phase. So we are familiar with this, so essentially this is diffuse alveolar damage, or ARDS. When you get to the fibrotic phase here, then you can see how you get fibrosis here. Of all these fibroblasts and collagen deposition along the air spaces here with this diffuse alveolar damage pattern. So we will have then on radiology progressive parenchymal consolidations or diffuse ground glass opacity similar to ARDS. You can see the rapid progression of disease here. And then on CT, We can have consolidations that are more extensive in the dependent portions of the lung, because a lot of this represents atelectasis because of these stiff lungs. So there is this gravitational dependence of the opacities, and you can have ground glass opacities elsewhere also. And then when you get to the fibrotic phase, we can see these opacities with traction bronchiectasis. So this is what we expect to see as we get progression of ARDS. There is no honeycombing here in this disease. So here we have a 48-year-old smoker with shortness of breath. So which of the idiopathic interstitial pneumonias is this? Well, here we notice that the predominant finding is ground glass opacity. So these extensive areas of ground glass opacity associated with smoking. This is desquamative interstitial pneumonitis. So desquamative interstitial pneumonitis results from accumulation of macrophages here, alveolar macrophages in the alveoli, in the air spaces. So this is some kind of immunological reaction to smoking, where you get recruitment of these macrophages into the alveolar air spaces, and that's what results in the ground glass opacity that we see on the CT. So a better, more accurate term for this would be alveolar macrophage pneumonia. So the term DIP is a misnomer, because Lebo, when he was describing this disease, thought that these cells were desquamated pneumocytes. So we know that that is not the case. These are alveolar macrophages. This is also a temporally homogeneous process. There usually is not much fibrosis associated with this. So it's rarer than idiopathic pulmonary fibrosis. It is associated with smoking. 90% of patients are smokers. So this represents a form of lung reaction to smoking, and it is less likely to progress to fibrosis. So on pathology, we will see these alveolar macrophages there within the air spaces. You may have ground glass opacity, especially at the lung bases and the periphery of the lungs. Lung volumes are usually preserved, and the predominant finding on CT will be ground glass opacity. As you see here, these patients are smokers, so there might be these areas of central alveolar emphysema that is associated with this disease. So usually there is not much honeycombing associated with this. This can get better if the patient stops smoking. So you see here the ground glass opacity, much of it has resolved here. If the patient stops smoking, and sometimes even treatment with steroids can result in improvement. Now here's another smoker who has shortness of breath, and here we have central lobular ground glass opacities. So which of the idiopathic interstitial pneumonias gives you central lobular ground glass opacities and is associated with smoking? Well, that is respiratory bronchiolitis interstitial lung disease. So this is really on the same spectrum of disease as DIP. It's just the location of the alveolar macrophages that is different. So here the macrophages will accumulate around the central lobular bronchiole as opposed to predominantly within the air spaces. This also improves with steroids and cessation of smoking and does not progress to fibrosis. So here we will get accumulation of these brown pigmented macrophages in the respiratory bronchioles here surrounding the air spaces. It's also a temporally homogeneous process. And as we've said, it's a part of the spectrum of disease of DIP and RBILD. So with RBILD, the macrophages are confined to the parabronchiolar air spaces. With DIP, they are more diffuse with more parenchymal involvement. So this finding of respiratory bronchiolitis, these macrophages around these small airways, we can see this commonly in smokers. It is only when they are symptomatic that we give them the diagnosis of RBILD, respiratory bronchiolitis associated interstitial lung disease. So the histologic finding of respiratory bronchiolitis we can see quite commonly in smokers, in lung biopsies of smokers. So these patients might have a reticulonodular pattern with some bronchial wall thickening. This has been called the smoker's chest, this kind of interstitial pattern that was quite common in heavy smokers. And on CT, we will see a central lobular distribution of ground glass opacities, as we see in these examples here. Now, this can be diagnosed without lung biopsy if it has typical CT findings, and a bronchoalveolar lavage shows lots of macrophages in the lavage fluid, so-called smokers' macrophages. So RBILD, central lobular areas of ground glass opacity, and this can get better with cessation of smoking, as in this example. So moving on, here we have a case of nodular opacities here, a reticular nodular pattern at the lung bases. We can see nodular opacities on CT. These nodules have somewhat of a perilymphatic distribution of nodules, but the other finding here are cysts. So cysts here in the lung with perilymphatic distribution of nodules. Which of the idiopathic interstitial pneumonias will give you this pattern? This is lymphoid interstitial pneumonitis, or LIP. So this is a diffuse hyperplastic lymphoid infiltration of the interstitium. So whether this is a primary idiopathic disease is somewhat controversial. So in many cases we will see this pattern in patients who have some underlying autoimmune disease. So it's a histologic variant of pulmonary lymphoid hyperplasia with predominantly interstitial changes. So again, whether this exists as an idiopathic disease, controversial. Most cases we will see LIP associated with some underlying autoimmune disease, especially Sjogren's, rheumatoid arthritis, SLE, HIV we can see it associated with, and then some of these other diseases that I've also listed here that we can find an LIP pattern. So in most cases, patients with LIP will have some other underlying autoimmune disorder. So this idiopathic form of LIP is described in the literature in this way. Sometimes it might respond to steroids. Some cases might progress to fibrosis. Whether it has a malignant potential or not is also really undecided. Some cases might progress to low-grade B-cell lymphoma. The important thing is, if we have LIP on a biopsy, we really do want to rule out any underlying autoimmune disease in these patients. So in the LIP pattern, there's a polyclonal proliferation of lymphocytes in the interstitium. Might also find lymphoid follicles here on the biopsy, as we've described there. The manifestations on radiology can be, there's a large variety of manifestations. You can have a lower lobe reticular nodular pattern. You might have alveolar opacities, mixed opacities. You might have nodular opacities, as in this example. You might have bronchovascular thickening. The cystic air spaces, that tends to be the most specific appearance on CT. Some patients might also have enlarged nodes. So perilymphatic nodules, these cystic lesions here within the lungs, the cystic lesions tend to be the most specific lesions for LIP. So that if you see that, then you might suggest LIP for the underlying diagnosis. It is a cause of cystic lung disease. So we can have cysts with ground glass opacities, as in this example. Here we have another example with smaller cysts here scattered throughout the lungs. More examples of cystic disease here with ground glass opacity. This one responded to steroids. You can see the ground glass opacities have, most of them have resolved in this example. So we can have ground glass opacity, we can have cysts, we can have ground glass opacity and cysts. So the manifestations of LIP are quite variable, but it's the cystic lesions that really are the most specific, and if we see that, then we should consider LIP in our differential diagnosis. Now, which of the idiopathic interstitial pneumonias gives you this appearance? So here we have a subpleural distribution of abnormalities and fibrotic changes with architectural distortion, but notice that it is predominantly here within the apices and within the upper lungs. So this is the most recent described idiopathic interstitial pneumonia, pleural parenchymal fibroelastosis. So here we get fibrosis predominantly in the subpleural regions, in the apices, and in the upper lung distribution. This is probably not something that you're going to diagnose prospectively. If you see changes like this on CT, you might suggest sarcoid or tuberculosis, but as the idiopathic interstitial pneumonia, this is PPFE. So it is rare. It affects the upper lobes. Pneumothorax is a common complication, has a high mortality. So on high-risk CT, we will see subpleural thickening, consolidations, traction, bronchiectasis, but it's that distribution that is most characteristic, this subpleural upper lobe distribution of disease. So when we look at our idiopathic interstitial pneumonias, this can get quite confusing, but try to remember what is different. What are the differentiating features of each of these entities? So idiopathic pulmonary fibrosis, we look for honeycombing, reticular, peripheral, subpleural, basal distribution. For NSIP, predominantly ground glass opacity. We may have reticular abnormalities, traction, bronchiectasis. Again, it can be basal distribution, but subpleural sparing is the most specific feature here. Cryptogenic organizing pneumonia, consolidations in a peripheral or subpleural and peribronchiolar distribution. AIP is essentially idiopathic ARDS, so you will have consolidations that can be diffuse with gravitational dependence, and bronchiolectasis or traction bronchiectasis in the fibrotic phase. DIP, smokers, ground glass opacity, basal and subpleural distribution. RBILD, also smokers, same spectrum of disease with central lobular nodules. LIP, we can have nodules, peribronchial thickening, ground glass opacities, but the cysts tend to be the most specific feature. And for PPFE, it's the distribution of the fibrosis that is most typical, apical subpleural fibrosis within the upper lobes. Now, are we done with pulmonary fibrosis? No, because there are other diseases that can also give you pulmonary fibrosis, especially at the lung bases, besides the idiopathic interstitial pneumonias. So in this example, we're showing you a CT, somebody with some honeycombing, opacities, traction bronchiectasis, predominantly peripheral distribution here, but there is another finding that you can see on the soft tissue windows that helps you with the diagnosis. Notice the pleural thickening and the pleural calcification. So this patient has had exposure to asbestos. This is asbestosis. So other causes of pulmonary fibrosis, especially in a lower lung distribution that might be similar to UIP and NSIP, but we can see this with asbestosis. We could see this with collagen vascular diseases, especially scleroderma, rheumatoid arthritis. There is this newly described entity called IPAF, interstitial pneumonia with autoimmune features. So this is when patients have interstitial lung diseases plus features of some systemic autoimmune condition without a definitive diagnosis of that autoimmune condition. And then there are drug reactions that can also give you pulmonary fibrosis. You must always exclude hypersensitivity pneumonitis whenever you're dealing with a case of pulmonary fibrosis. So asbestosis results from inhalation of asbestos fibers. So the macrophages try to ingest these fibers, they die, release their enzymes, and then that's what causes the fibrotic reaction in the lungs. The fibers can also penetrate the lung tissue and travel to the periphery of the lung. They're kind of needle-like here, and that's what can result in the pleural changes that we see associated with asbestos exposure. So on histology, pathologists might find asbestos bodies and fibers, but the changes that we see in the lung have a long latent period of about 10 to 40 years. So the criteria for making a diagnosis of asbestosis: history of asbestos exposure, restrictive lung disease, and abnormal findings on imaging studies. So on asbestosis, we will find interstitial disease, tends to have a basilar distribution. Look for pleural abnormalities, pleural plaques, and of course CT is going to be better than chest radiographs in terms of making the diagnosis. So when there's widespread interstitial disease, you might have this shaggy heart appearance, which can be associated with asbestosis. High-risk CT, of course, is more sensitive. Normal high-risk CT does not exclude asbestosis, but the early findings of asbestosis usually are in the subpleural regions at the lung bases. Hence, this is where prone and CT might be helpful in terms of making the early findings of asbestosis. So the earliest findings: posterior and basal subpleural dot-like opacities We would look for findings of fibrosis, subpleural lines, parenchymal bands. Of course, evidence of exposure to asbestos is very important, pleural thickening and pleural plaques. So here on this prone CT scan, some of the earliest findings of asbestosis are these subpleural nodules, these tiny little nodules in the subpleural distribution. So these probably represent areas of central lobular and peribronchiolar fibrosis. Peripheral abnormalities here, another prone CT scan, some reticular abnormalities here in a subpleural distribution. So if this patient has a history of exposure to asbestos, then these are early findings of asbestosis. More advanced cases, we can have irregular interlobular septal thickening. You might have honeycombing, traction bronchiectasis. So here you can see the reticular abnormalities here and some traction bronchiectasis in this example of a patient with asbestosis. Subpleural lines, these are lines that are parallel to the pleural surface. So this also can represent areas of peribronchiolar fibrosis or atelectasis, and this can also be associated with asbestosis, although this is not specific for asbestosis. And then parenchymal bands, these are these lines that are kind of at right angles to the peripheral surface. Also, these might represent areas of atelectasis or fibrosis here associated with asbestosis. Again, these are not specific for asbestosis, but this finding can also be associated with asbestosis. And then looking for evidence of asbestos exposure, if you have interstitial abnormalities in the lung in a patient with pleural disease like this, with pleural thickening or pleural calcification, then asbestosis goes at the top of your differential because these pleural manifestations are indications of asbestos exposure. And so these pleural abnormalities we will see in 80% of patients with asbestosis. So pleural plaques can be subtle, so look for them whenever you have a patient with fibrotic lung disease, as we see here. So look for this abnormal areas in the pleura. That might be an indication that we're dealing with the case of asbestosis, these asbestos pleural plaques. The most characteristic plaques that are associated with asbestos are these diaphragmatic calcified pleural plaques. So if we see diaphragmatic calcified pleural plaques like this, then that's very specific for asbestos exposure. So that tells us that the patient has had asbestos exposure, as do these other pleural calcifications. And so if we have interstitial lung disease in a patient like this, we can put asbestosis at the top of our differential diagnosis. So here's another case who has some interstitial lung disease. I will ask you to ignore the enlarged heart in this case, but if we look very carefully here in the mediastinum, you might see a clue here that gives you the diagnosis. So I'll give you a second to look at that. Then I'll show you the CT here. So here's a patient who has peripheral interstitial disease here, ground glass opacities, some areas of traction bronchiectasis, but the clue on the CT, what is the clue? The dilated esophagus. And you can see that also on the chest radiograph. So here there's the dilated esophagus here on this chest radiograph. That tells you then if you have a dilated esophagus associated with interstitial lung disease, then we are dealing with scleroderma. So this is a board favorite to show you somebody with interstitial lung disease on CT with a dilated esophagus. So if we see that combination, we will put scleroderma at the top of our list. And then here are bony manifestations here of scleroderma with acroosteolysis here in the periphery of the digits. Another patient who has interstitial lung disease, and if you look carefully at the chest radiograph, there is a clue here. Look carefully at the shoulders and you will see this bilateral arthropathies, narrowing of the shoulder joints bilaterally. This is a patient with rheumatoid arthritis. So rheumatoid arthritis also can give you interstitial lung disease. This can be associated with a UIP pattern. So rheumatoid arthritis is another connective tissue disease that can give you pulmonary fibrosis. So collagen vascular diseases can be associated with pulmonary fibrosis. The most common ones, scleroderma. There you look for the dilated esophagus, rheumatoid arthritis. So rheumatoid arthritis tends to be associated with a UIP pattern. Scleroderma is associated with an NSIP pattern. Less common, but in other diseases, SLE can give you diffuse pulmonary hemorrhage or diffuse alveolar damage as far as the patterns that we might see. Myositis here can give you NSIP or organizing pneumonia. In Sjogren's, that can give you an NSIP or an LIP pattern. And then IPAF, which we touched upon, this is interstitial pneumonitis with autoimmune features. So these are patients who have interstitial lung disease and manifestations of some underlying systemic connective tissue disease, although the manifestations of it are not specific enough to arrive at a precise diagnosis. So when we're dealing with connective tissue diseases, is there a way we can differentiate idiopathic pulmonary fibrosis, the pattern on CT of idiopathic pulmonary fibrosis versus fibrosis from connective tissue diseases? Well, these are signs that are more common with connective tissue diseases. The anterior upper lobe sign, concentration of fibrosis in the anterior upper lobes with relative sparing of other parts of the upper lobes. Lower lobe may be involved. Exuberant honeycomb sign, extensive honeycomb cysts greater than 70% of the fibrotic portion of the lung. The straight edge sign, here we have isolated fibrosis to the lung bases without substantial extension along the lateral margin on coronal images. So what are some examples of this? Here's the anterior upper lobe sign. We have a concentration of fibrosis in the anterior portions of the upper lobes with relative sparing of other parts of the upper lobes. We do have lower lobe involvement in these cases. So this is more typically associated with connective tissue diseases. Exuberant honeycombing sign, we have extensive honeycomb cysts greater than 70% of the fibrotic portions of the lung. This is exuberant honeycombing. Again, this is more typical of underlying connective tissue disease as opposed to idiopathic pulmonary fibrosis. And then the straight edge sign, where you have fibrosis at the lung bases without substantial extension along the lateral margins on coronal images. So it gives you kind of a straight edge, a sharp demarcation between the areas of honeycombing and the areas of more normal lung. Again, this tends to be associated with connective tissue disease as opposed to idiopathic pulmonary fibrosis. Now, hypersensitivity pneumonitis. You always need to consider that when you're dealing with interstitial lung disease. You must differentiate hypersensitivity pneumonitis from the idiopathic interstitial pneumonias. So if we have fibrosis with ground glass opacity and air trapping, so if we have mosaic attenuation, if you have a substantial amount of air trapping, then that might point you towards the direction of hypersensitivity pneumonitis as opposed to idiopathic pulmonary fibrosis or an idiopathic interstitial pneumonia. You can have pulmonary fibrosis associated with drug reactions. So drugs like nitrofurantoin, bleomycin, other cytotoxic drugs, these can also give you pulmonary fibrosis. So this is an example of nitrofurantoin giving you an extensive interstitial pattern from fibrosis in the lung. So here it is on CT. You see these reticular abnormalities and some ground glass opacities from the lung reaction to this drug. Chemotherapeutics like vincristine, adriamycin, these can also give you pulmonary fibrosis within the lungs. So pulmonary fibrotic changes, interstitial pattern, ground glass opacities, traction, bronchiectasis, so fibrosis in the lung, we can see that with chemotherapy. Bleomycin can resemble UIP in some cases, so bleomycin can also give you interstitial lung disease that is more extensive at the lung bases. Sarcoid usually gives you upper lung interstitial pulmonary fibrosis. Typical manifestations here, traction bronchiectasis, reticular abnormalities, but it tends to have an upper lung distribution. However, there can be cases, unusual cases of sarcoid that are more extensive within the lower lungs, as in this particular example that I'm showing you on this chest radiograph. So atypical manifestations of sarcoid might also be a consideration. Now, honeycomb lung, this is when we have extensive pulmonary fibrosis. So this is end-stage disease, and it can be any cause of pulmonary fibrosis, of chronic lung disease, can give you honeycomb lung that gives you these dilated respiratory bronchioles that would manifest as honeycombing on pathologic specimens or on imaging studies. So any of the diseases that we have studied, if they are severe and extensive enough, can give you honeycomb lung, and honeycomb lung is essentially end-stage diffuse pulmonary fibrosis. So any of the diseases that we have studied that can give you fibrotic changes in the lungs can result in honeycomb lung. So when we're dealing with a chronic interstitial pattern of lower lung distribution, if we're thinking about what can give you that pattern on a chest radiograph, well, we've talked about lymphangitic spread of tumor and bronchiectasis, especially from chronic aspiration. That can give you lower lung interstitial pattern on chest radiograph. But if we're talking about fibrotic lung diseases, idiopathic pulmonary fibrosis, that is certainly in the differential diagnosis. Sometimes NSIP can also be in the differential diagnosis. Collagen vascular diseases, scleroderma, rheumatoid arthritis, that is in the differential diagnosis. Asbestosis will be in your differential diagnosis. Drug reactions from nitrofurantoin, bleomycin, chemotherapeutics will be in your differential diagnosis. Atypical cases of sarcoid, remember sarcoid is usually upper lung predominant, that might also be in your differential diagnosis. So these are entities that would be in your differential diagnosis of pulmonary fibrosis in a lower lung distribution. Okay, for those of you that like mnemonics, interstitial pattern in a lower lung distribution, BADLAS, bleomycin, bronchiectasis, aspiration, drugs, DIP, lymphangitic tumor, asbestosis, scleroderma, sarcoid. So that is one approach you can make, although these will all have kind of subtle differences, and as we've seen when we look at high resolution CT. Now, what about if we're dealing with unilateral interstitial disease? So here we have a patient who has volume loss on this one side, and we see that there is interlobular septal thickening and some traction bronchiectasis here. So this looks like predominantly unilateral interstitial lung disease. Well, what could this be? Well, there is a clue here for this particular case on the CT scan. Notice the surgical clip. Right, surgical clip. So what does this patient have? Well, this patient has had a lung transplant. So this patient had bilateral interstitial lung disease and had a unilateral lung transplant. So this is the transplanted lung, which is the more normal appearing lung, and this is the native or diseased lung in this particular case. So what is our differential diagnosis for unilateral interstitial disease? Well, we can see it with reperfusion pulmonary edema. We've talked about re-expansion or reperfusion pulmonary edema. That can look like unilateral interstitial disease on a chest radiograph. Lymphangitic carcinomatosis, breast cancer, lung cancer can give you an asymmetric distribution of lymphangitic carcinomatosis. Radiation therapy can give you asymmetric distribution of fibrotic changes, and as in this example, lung transplant can also give you this appearance of unilateral interstitial lung disease. So in summary, when we're discussing these interstitial lung diseases, if we're looking at the chest radiograph, we want to decide, is it upper lung versus lower lung predominant? And that can help us in our differential diagnosis. We've talked about differences on the high resolution CT appearance that can differentiate one entity from another. Ancillary findings are very important. Pleural plaques can point you in the direction of asbestosis. Dilated esophagus can point you in the direction of scleroderma. Lymphadenopathy, maybe we're dealing with sarcoid or lymphangitic tumor, and we've covered other ancillary findings also. The clinical information is the most important information that you would like to obtain, and you want to put that together with the findings that you have on your imaging studies to formulate a differential diagnosis that makes the most sense for the particular patient that you are dealing with. So that concludes our talk for today, and I thank you for your attention, and I will see you next time.